And good afternoon for joining today's webinar, which is titled Cultivating Mental Health After Brain Injury. My name is Rachel Ishak, and I am a community outreach specialist at the Brain Injury Alliance of New Jersey. The Alliance is a nonprofit organization with a mission to provide education, awareness, prevention strategies, advocacy, and support for those who have been affected by brain injury. So we have a couple of upcoming webinars, which you can view and register for on our website, but I've posted here just a couple of them. Next, we have coming up Brain Injury Caregiving, Navigating Challenges and Helpful Tips on February 19th. And on March 4th, we have one on navigating dating and relationships after brain injury. So feel free to register for those on our website and join us for those upcoming webinars. We also have some other trainings and opportunities available. So on March 6th and March 12th, we have our free regional trainings for health and human service professionals. And these are open to anybody who's in the health and human service field and is interested in learning more about brain injury. So we have two locations, East Hanover and Cherry Hill. You can register for these trainings on our website or using the link that we put into the chat. And lastly, we have our upcoming annual professional seminar on May 14th. This is an opportunity to attend, receive CEU credits for your discipline, and hear about different information and research in the field of brain injury. So just a few housekeeping notes before we begin the presentation. The attendees' microphones have been muted. So if you have questions during today's webinar, please type those questions into the Q&A box, and we'll get to as many questions as possible at the end of the presentation. The webinar is being recorded, and it will be available for viewing afterwards on the BIANJ website, or you will also receive a link to it in a follow-up email. So if you are looking for a certificate of attendance for today, we will have a post-webinar survey that we'll put into the chat. You have to complete that survey in order to receive your certificate. And once you complete the survey, you will automatically receive an email with the certificate of attendance. But even if you're not looking for a certificate of attendance, we really value your feedback and we read every single response. So please complete it and help us, figure out what we can do better to continue bringing this information. So our presenter for today is Joshua Cohen. After graduating with a BA from Johns Hopkins University, Dr. Cohen went on to earn a PhD in clinical psychology at the University of Michigan. He then completed a 2-year postdoctoral fellowship in rehabilitation psychology and neuropsychology at the University of Michigan Hospital. Much of Dr. Cohen's work as a neuropsychologist has included helping patients in hospital settings, including the JFK Center for Brain Injuries and Children's Specialized Hospital. Dr. Cohen currently serves as faculty at Rutgers University, where he teaches graduate students about various topics related to neuropsychology. He also appreciates the opportunity to provide clinical services to individuals and their families through Two Rivers Behavioral Health and Neuropsychology located in Oceanport. So it's my pleasure to welcome Dr. Cohen.
All right. Thank you, Rachel. I appreciate the introduction. I appreciate you all having me here. I created this little presentation here with mostly keeping people who have lived through brain injury in mind. So I understand there are probably a lot of professionals on this call as well. I hadn't fully expected that, but hopefully there's something for you as well. But anybody who serves people with brain injury or lives with people with brain injury or loves somebody with brain injury or is experiencing persistent symptoms from brain injury themselves, this is who I had in mind when I created this presentation. So I'm just going to share my screen, a few slides. And yeah, so the first, this is the title here, as Rachel mentioned. And hang on a second, she already kind of did my introduction, so I'm not going to go through my history. I always like to know who's presenting to me when I'm listening to a presentation, like who is it that's giving me this information? So she already shared with you a bit about my education. A little piece about me, I grew up in Spring Grove in York, Pennsylvania. So that's another little piece. I also spent almost 2 years living in Argentina after college. So I do see a lot of clients, or have seen a lot of clients that are primarily Spanish speakers, having learned Spanish while I lived there. I'm going to move through this slide. And yes, I worked in hospital settings. Again, Rachel already said all this. Currently at Rutgers, I teach graduate students, but I'm also just got a new appointment there at the Rutgers Center for Adult Autism Services, and where I'll be a director of their psychological services clinic there. And I do plan to bring um, services for people with persistent symptoms from brain injury as well, because it's going to be under, there's a whole kind of movement at Rutgers for serving people who have neurodivergent people who have unique challenges, both for college students, but then also people in the community. And many people put people with a history of TBI in that category. So anyway, moving along, some people might not know what neuropsychology is. And so you're like, well, okay, so you studied neuropsychology, Josh. What is that? So it is, in a nutshell, it's a cross between neurology and psychology. So neuropsychologists are psychologists. And whoops, sorry. Um, but we focused specifically on the study of brain and behavior relationships. And you can see what I've written here. It's similar to, so, at the basis of our training is as a psychologist, but then we go into a little more about neurology, and particularly the functions of the brain and how it relates back to people's emotional functioning, their cognitive functioning, and their behavioral functioning. And you can see here, I've listed some other related fields. A lot of times neuropsychologists are working closely with rehabilitation psychologists, which I'll talk more about in the next slide. There are behavioral neurologists that overlap with neuropsychology. These are neurologists that specialize in understanding the behavior, how behavior is affected by neurology as well. And then certainly neuropsychology works closely with speech and language pathology, other clinical psychologists. Depending on the age of somebody with a brain injury, might work with school psychologists, and then there's physiatrists and occupational therapists also. A lot of overlap with those fields. I wanted to just raise awareness. A lot of people don't know about rehabilitation psychology and rehabilitation psychologists. And I think it's useful for people to know about rehabilitation psychologists because they are a great resource for people with brain injury. And it's hard to find them, but they're often in hospital settings or outpatient settings related to hospitals. And I think of them as kind of being on the treatment side of what neuropsychology does. Neuropsychologists, some of them will provide treatment like therapy and cognitive rehabilitation, but a lot of neuropsychologists are primarily doing neuropsychological evaluations, which many of you may already know what that is, and I'm happy to describe that later if people like. And then rehabilitation psychologists will do a lot of the therapy. They're highly trained in different forms of therapy for really a lot of people that have chronic illness or injury, and brain injury is one of those categories of people that they may help. So what is a brain injury though? Because a lot might fit under that heading. And this is a definition from the CDC, Center for Disease Control. A disruption in the normal function of the brain that can be caused by a bump, blow, or jolt to the head, or a penetrating head injury. And so there's something to notice about this definition. It's not based on structural changes in the brain, although we do think of there being structural changes with brain injury. It's based on function. You can see here. So it says disruption in normal function. And that's really what I'm going to be talking about most today, is how does this affect function and mental health in the big picture. And so I'll be talking about, I'll be saying traumatic brain injury, which people usually think of as a blow or shaking of the head. But a lot of what I say might apply to other forms of brain injury. There might be people on this call that have other forms of brain injury or know people with other forms of brain injury, like maybe an anoxic brain injury. Somebody's lacking oxygen to their brain for a period of time and injured their brain that way, or perhaps a stroke or some other way of acquiring a brain injury that wasn't a blow to the head or shaking of the head. But when I'm talking about, I'll be saying TBI quite frequently. And I'm just sort of orienting all of us what we're talking about, or what I'm talking about when I'm talking about TBI. So you'll hear me talk about different categories of TBI, mild, moderate, and severe. And there are not clear definitions of these that everybody agrees upon in the field of brain injury. So what one person might call a mild brain injury, and another clinician might refer to as a moderate brain injury. Um, and also, I want to be clear. So this is just a little table here showing different ways that brain injuries are categorized. So you can see. I don't know if you guys can see my cursor when I move it, but so you can see there's a Glasgow Coma Scale, which is a measure that um, neuropsychologists and other clinicians in hospital settings will use mostly when somebody's in the hospital to measure their level of consciousness. And it's based on measuring things like eye movement, how well somebody can respond to requests to move their eyes, and verbal responses and motor responses. And then they'll get scored in some kind of way based on how they respond to these commands, and they can be categorized at that point in time as having mild, moderate, or severe level of brain injury. Also, sometimes brain injuries categorized by how much loss of consciousness there was, how much time was the person unconscious, or had a different level or altered level of consciousness. And then post-traumatic amnesia, which is amount of time that a person is not forming new memories. You know, so somebody has traumatic brain injury and they can't make new memories for an hour, and according to some system of categorization, that person would be considered as having a mild brain injury. But then after an hour or two, they're able to remember, form new memories, then that would say something about their level of brain injury. But like I said, so these are different ways of categorizing, and there's not in the field one way that everybody agrees to categorize it. Sometimes you'll hear about, if there's a change in consciousness or a change in memory function and some structural abnormality, that might automatically put somebody at least in the moderate level, if not severe. And we don't have to get into all that. That's not what this talk is really about. But what this talk is about is mental health. And so I wanted to say this little piece in purple here, that when you hear a clinician like a physician or a psychologist talking about mild, moderate, severe, they're talking about some way of categorizing the brain injury. They're not talking about how much this person is suffering. So I've certainly met my fair share of patients with severe brain injury that seem to suffer very little. Their mental health, there is good. They're feeling good. They think they're functioning quite well. Now, people around them might say otherwise, but they're not depressed or anxious in particular, or anything, or any other kind of typical psychological challenge like that. So, but they've been categorized as having a severe brain injury because they were in a coma for 2 weeks and they have had, a month of post-traumatic amnesia after the injury. And so a year later, even though they're doing well in many regards, they're considered to have had a severe brain injury. And then you'll have somebody who had a concussion, which is a mild traumatic brain injury. And we can debate whether those two are the same. I tend to use those terms interchangeably: mild traumatic brain injury and concussion. and yet they have severe consequences to their their life because of that concussion. And so in some ways, I've had people tell me, it's almost offensive to them that they have a concussion and it's called a mild brain injury because it's changed their life so much. And I have to explain, well, it's not, it's mild in terms of these categories, different ways of categorizing, but not in how much you're suffering from it. Okay. Uh, so I wanted to just spend a little moment talking about concussion and persistent symptoms after concussion, partially because most brain injuries, about 75% of them are in this category. Most brain injuries in America and the world actually are considered mild traumatic brain injuries. And so most people, are better within, a month. Most people after concussion, their symptoms are better within a month. Um, some people might take a little longer. And then there's some people that symptoms last for a while. And I'm sure there's some people on this call that are very familiar with these symptoms. And not that everybody would have all of these symptoms, but you can see here there's a wide range and there's a lot of heterogeneity. In other words, there's a lot of two people with the same class, same categorized mild traumatic brain injury could have a different profile of symptoms or even experience any one of these symptoms very differently. Um, you know, so just to point that out, no two people with brain injury are exactly alike, but there's enough commonalities that we can say something about what is possible here. Um, I do think this category, the mild traumatic brain injury, is the least well understood by the general public and also many healthcare providers. Um, it can often, I'm going to talk a little bit more about in a bit about how it can be mistaken for other types of challenges, other mental health challenges. So just wanted to talk a little bit about the definition of persistent symptoms after concussion. Um, it's had different, I'll talk on the next slide about how it's had different names. When I first started in the field, it was post-concussion syndrome. I'll talk about how it doesn't apply anymore. But this is the most recent um, definition of like a diagnosis, so to speak, of what people can experience after concussion. So I'm just going to read this with you, and then we'll discuss it, or I'll talk about it. So it says here, most concussion symptoms improve significantly within 1 month for otherwise healthy individuals. Number and severity of concussion symptoms are typically greatest within hours of the injury and gradually improve over days. So that's what most people experience. Most people get better. But persistent symptoms after concussion are characterized by the following. Symptoms are not improving or worsening in a number and or severity over days to weeks after injury. Persisting symptoms may be related to premorbid, comorbid, or resulting factors from the injury, and I'll talk more about that as well. These persisting symptoms may be present due to the injury itself, but often are due to other biopsychosocial factors as well. And this is why we say persistent symptoms after concussion, because some of these are directly related. Some of these symptoms are directly related to the concussion, and some are related to indirectly because of all the effects on the person's life in other ways. Symptoms cause distress or disability more days than not, and symptoms interfere with partial or full return to typical activities such as school, work, sport, and or social roles. And as it says here, consultation with multidisciplinary brain injury professionals is recommended for individuals with persisting and disabling symptoms. And this is all taken from a paper from the Journal of Physical Medicine and Rehabilitation from 2022. Okay. So I'm still caught in using the term persistent post-concussion symptoms which replaced post-concussion syndrome, although you'll still hear plenty of professionals using that term. I mean, the reason I've stopped using that term is it's debatable whether we can call it a true syndrome because it's hard to distinguish it from other syndromes. If you think of a syndrome as a collection of symptoms that tend to hang together and are distinguishable from other syndromes, other conglomerates of symptoms, then this is not as distinguishable. There are people that have very similar symptom profiles that might just have chronic pain or a combination of chronic pain and depression, chronic headaches, excuse me. So probably the most accurate term we can say is what I just showed you on the last slide from that paper, persistent symptoms after concussion. And because it so overlaps with other mental health issues, a lot of times psychologists are really relevant to determining if this applies, this persistent post-concussion symptom profile applies, or is this, let's say major depression or something else that would also be considered quite a normal mental health reaction given what the person has lived through. So yeah, just to say here's some of there are many symptom profiles that could be similar to persistent symptoms after concussion. So depression is, a lot of people with depression, they might have headaches, they might have irritability, trouble sleeping, or sleeping too much, and so you can imagine somebody who's in an accident and it's not clear whether they ever had a concussion or not, but they're having these same symptom profiles. You can see that'd be difficult to distinguish, but important because the treatment might be a little different. And then other types of somatic symptom disorders, not to get into that, but related to body symptoms, psychological factors contributing to body symptoms, and then PTSD, post-traumatic stress disorder. A lot of people with PTSD. I mean, I remember a study that came out about that had categories of vets who had been to Afghanistan and Iraq. Three categories, three samples. One sample of people of vets had been to war and they had a concussion. It was very clear. Another group had PTSD but no concussion, and then there was a third group that had PTSD and a concussion. What was interesting to me about this study, this came out a few years ago, was that on neuropsychological testing, so testing of cognitive function, thinking skills, and psychological testing, the post-concussion group and the PTSD group were not distinguishable. But the group that had both, they had more severe symptoms, and there was a significant difference between them and the other two groups in terms of their symptoms. So again, highlighting that there's a lot of overlap in this mental health profile. And then people that have anxiety disorders, they can also look a lot like a post-concussion syndrome. Post-concussion symptoms. And same with just chronic pain elsewhere in the body, and certainly chronic pain in the neck and head. I want to be cognizant of the time here. Make sure we have time for some question and answer. There's a lot of reasons, so one of the challenges is that concussion in particular, but brain injury and mental health overlap so much. And if something gets in the way of treatment, it can make the mental health challenges greater and more challenging to treat down the road. So, it's getting much better, but still problematic, and used to be much more problematic, that people would go to the ER, and if they had a head injury, particularly a concussion, there would be poor follow-up. Maybe they'd be told you should go see this or that person, or they might not even be told. They say, you have a concussion, rest up, you'll be better in a week or a couple days. give us a call if not. But people wouldn't get the help they need afterwards, and then they might get depressed because of their symptoms, and then their symptoms would be perpetuating because of that. Um, and in addition to the head injury, there's also racial and cultural disparities and follow-up post ER from head injury. So you know, Latino Americans and Black Americans tend to have there tends to be less follow-up after ER, at least in this country, than for white Americans. So it's something that, this is more for those professionals out there to be aware of, any biases there. And then there are gender factors I put here. And there's on this whole slide, we could talk for a few hours just about this slide, but that's not what this talk is supposed to be about. But it's just something to be aware of. So, and the gender factors also play into the mental health, long-term mental health outcomes. So, it's a little bit stereotypical, but it still remains true that men typically do not talk about their symptoms as much. So they might not divulge to healthcare providers how much they're suffering, and then down the road it really gets to them, and then it's already harder to treat at that point. Not impossible, of course, but they're less likely to be upfront. So people that, whether sometimes it's family members around them, help to communicate with providers about what's really going on with a man after he's had a head injury. And then there's multiple other gender factors, but with women, sometimes, unfortunately, I can see they might get dismissed too quickly when they make complaints about what's going on with them and not get the full treatment that way. So again, much more to say there, but I just wanted to, touch on this. And then insurance status. So, it's hard to find providers, hard to find in-network providers. And if socioeconomic status plays into that as well. So just all factors to be aware of. And if there are more questions about it, we can talk about it during the Q&A period. Just to talk a little bit about moderate and severe TBI. Again, there's a lot of differences in how people present. But something that I think is important for mental health is that with especially severe TBI, not always, but more often than with mild TBI, a person is less aware of their cognitive deficits and behavioral or physical changes. So, I've met people that, when I was working in the hospital systems and even in my private practice, where they've been in, let's say they've been in a coma for a month, and now they're back, they're kind of much more conscious, and they're fully conscious, and they're in their mind they're functioning great. And if you ask them, you think you could go back to college right now, or you think you could go back to work, and they say, yeah, I'm ready to go. And meanwhile they have a terrible memory or severe memory problem or something like that. And because of that lack of awareness, it's really frustrating for them when everybody around them is telling them they can't do something. And you can see how that would contribute to mental health when they're being told that enough times in a row. Because sometimes a person goes home and they have persistent symptoms. They have what might be considered permanent symptoms or permanent changes in their functioning, but they're not fully aware of it. They don't see it. So that's incredibly frustrating for them. And then people with severe TBI are more common just by the nature of how they got the TBI, are more likely to have some co-occurring medical condition. They might have seizure. This is just some examples you see here, but there could be, you can imagine somebody's in a major car accident, they might have other things happen to their body in that process. And that total effect from the head injury and other injuries on their functioning, you could imagine, contributes to their mental health afterwards. And then aphasias, which are language problems in short. And there's a lot to say about aphasia, but language comprehension problems, language expression problems. And seeing as language is one of the main ways we connect with people, um, you know, you can see how you can imagine how this would impact mental health if people are having trouble comprehending those around them, and for that matter, might not even be aware that they're having trouble comprehending those around them. So they could be misreading the situations, misunderstanding things, um, and not understanding, why others aren't, wanting to converse with them as much or connecting with them, or why people aren't understanding them, and that would I can get to people psychologically, of course. And then people with severe TBI are more likely, of those people with mild TBI could also have some problems here, but have some sort of sensory processing challenge. I'll talk more about that later, but a common one might be somebody has what's called a left neglect, and then they're just not aware, not paying attention to things on their left, and in general, that person also is going to have also tend to be the kind of person not aware of their problems on a bigger scale, and how it impacts them on a bigger scale. And so, family members get frustrated with them. They get frustrated with family members. And but anyway, some of it could just be they're just not processing what's going on in front of them. And then, of course, people with severe TBI or moderate TBI can also have any or all of the same symptoms as somebody with mild TBI. They may or may not have that as well. So I think it's important to understand how cognitive function, can impact mental health. But like, what do we mean by cognitive function? That's a term that healthcare professionals use, and there's many categories of cognitive function. So this is not an exhaustive list. This is just like a primer, but sensory processing I just mentioned, which could include visual, so seeing, hearing, smelling, touch, taste, vestibular, like balance, proprioceptive, where one's body is in space and being aware and being able to sense that. Also, motor function can fall under the heading of cognitive in the sense that there's coordination is a complex brain function. Motor planning, being able to sequence movements. Attention, there's a lot to say about attention, but one thing that's important to understand is attention regulation. So somebody could be really good at paying attention to something that they're interested in or grabs their attention, like a movie or a video game, but then have trouble regulating their attention. So moving it away from that or paying attention to something that they find less interesting. But then we also have like sustained attention, being able to select attention and block out something else. And then alternating between paying attention to this, paying attention to that. So, just as a simple example, somebody having to, has a brain injury, and then they try to, after some time, go back to a college lecture. In the process of taking notes, they have to alternate their attention between listening to the professor and what they're writing in their notes, while they're also trying to block out any distractions around them. Divided attention is a tricky thing. Really, we don't divide our attention very well at all. Unless it's something that, one of the things we're doing, one of the tasks we're doing is really automatic. And so like, somebody, might be able to drive and talk on the phone, which we're not supposed to do, but say, you have Bluetooth or listen to the radio or something like that. You're dividing your attention between, so there's sort of an unconscious attention that happens with driving, and a conscious attention to the radio, and unconsciously paying attention to the road. So you can see a lot of that could be disrupted after brain injury. And the processing speed I have in purple here, because it's not necessarily attention, but it's related to attention in that processing speed is often slowed after brain injury. And so how much a person can process and pay attention to at once is limited. So you can see how I'll talk about how this relates back to mental health, but just to go through this list a little quicker here. Memory, different categories of memory. Um, I mentioned language before when I was talking about aphasia. Then we have visual spatial skills, like constructing things in one's mind or in the physical world, navigating through space, whether it's driving or walking in a new place. And then a big one that's sometimes feels abstract and hard to understand, but it's really concrete is executive functioning. So the ability to inhibit one's behavior when it's like inappropriate or it's an automatic response we want to inhibit, uh, or initiate behavior, start something. So people with severe brain injury, for example, might not initiate behavior. Then there's planning a few steps ahead, organizing information kind of automatically without having to try too hard, mental flexibility, kind of not getting stuck on something, the opposite of which might be perseveration. Many of you might have heard of that term, getting stuck on one idea or thought, and I'll talk more about that. And then there's more broadly, there's like a self-monitoring, being aware of myself as I'm moving through the world or doing anything. And part of that is working memory, which I have in two categories here. I tend to think of it as an executive function, but it has the word memory in it, which I think is almost unfortunate. And so it's also, you could categorize it as memory, but it's really holding things in mind while you're solving a problem or thinking through something, and then it's forgotten. So you have short-term memory, just retaining information in your short-term memory for like, 20 seconds or something like that. And then there's doing something, moving that information around, solving mental arithmetic, for example, would be a working memory task. Um, and then sequencing information naturally without having to try too hard. That's another executive function. Um, and then I also threw in there social cognitive functions like reading social cues, interpreting them, perspective taking in real time as a conversation's happening, for example, without having to think about it. Inferences being made about what's happening based on body language and tone of voice, for example. These are functions that can change after brain injury. So if you look at this list, you can see I could take any one of these and you could see how it would impact mental health. And I think it's important when you're talking to somebody with brain injury, or if you have brain injury, understand how changes in cognitive function can affect, how I'm doing psychologically or emotionally. Just give you an example, if somebody has a change to um, their ability to pay attention in a conversation, to sustain attention to a conversation, that might affect over time. People start to notice that they don't seem to be paying attention to what I say, so they get people speak to them less, or let's say they're less inhibited and they're saying slightly inappropriate things. People might want to talk to them less. Well, less social interaction can affect one's mental health. Um, Certainly memory, I'll give a couple case examples, but if somebody's not remembering things well or misremembering things, that can affect them socially, emotionally. Maybe they're not, they're not remembering something important about somebody else's life that they told them just yesterday. They're going to come off like they're a bad friend, just as an example. But I'll give more examples about this. But just to think about, okay, well, if somebody's seemingly depressed, we can't make it as simple as depression. Is there a change in cognitive function also contributing to that depression or anxiety? Certainly people can have anxiety or depression without any cognitive problems. But if we're going to help somebody who has depression, if the cognitive change is a part of it, then that might need to be addressed in some way, or at least be made aware of. All right. So I'm going to come back to that idea in a slide or two here. Okay. Excuse me. For the sake of time, I'm realizing I'm just going to put these up here without getting into too much detail here. But there are a lot of factors that affect one's mental health after a traumatic brain injury. So I've already mentioned the changes in cognitive function, pre-existing mental health challenges, which are extremely common, that people already have challenges with mental health, and then some of these some of these diagnoses actually raise one's risk for brain injury. For example, ADHD, people are slightly higher risk of having a brain injury to begin with, and then certainly if you have symptoms of ADHD after brain injury, they can get worse. Um, the circumstances around how the person got a brain injury, if it was a traumatic accident or a traumatic event, they might develop post-traumatic stress disorder independent of the brain injury. I say independent, it's not really independent, but just from the experience of that accident alone. Sleep problems. Sleep is so key to our mental health to begin with. And after brain injury, a lot of times people's sleep schedules change. They're either sleeping less or too much, or it's disrupted. And then changes in people's lives, whether that's changes to their employment, their role in the family. Maybe they were like the central, kind of had a primary role in the family that, of being in charge of a lot, and now that's changed. And changes in sexual function, things that affect relationships. These all can affect one's mental health. And when somebody's addressing mental health issues, it'd be important to know if any of these or other factors, this is again not an exhaustive list, are impacted and need to be addressed. And then I kind of touched on a lot of these. There can be personality changes that you could think of as part of mental health or not. Somebody could be not depressed at all or anxious at all or have any other typical mental health diagnoses, but their behavior, their personality has changed, and that will down the road impact their mental health. This last bullet point, emotion regulation difficulties, is a big one. So one's ability to regulate anger or anxiety, fear, or even like laughter. People laughing at inappropriate times. So you can imagine maybe these things don't bother the person experiencing them so much at first, but then they realize they have an impact on others, which then in turn affects them and their mental health. So a couple just quick case examples. So these are hypotheticals, not based on any one person, but based on the mishmash of all the cases in my head. So imagine like a 27-year-old single woman with a history of severe TBI who lives on her own, and now she has moderate to severe depression and anger. And picture that she has trouble with impulse control and memory problems, and think about how that would impact her mental health. So as an example, imagine this woman, her mother is highly involved in her life because her mother needs to be, because this woman has memory problems. Now, at the same time, this someone with memory problems doesn't remember what they don't remember. And so, someone who's 27 typically would be independent of their mother, now feels like her mother's overbearing with her, and like canceling her credit cards on her when she's like, well, these are my credit cards, mom, or her thinks her mom's interfering with her health care, dictating which doctor she can go to, but she's not remembering what she said to which doctor. She might be getting other, too many people involved in her treatment because she doesn't remember what's already happened well. So her mom has to be involved in her health care, right? So, but just having that at 27, when she feels like she should be independent, and now she's having, her mom involved in her life so much, this can lead to mental health challenges, which I would add also for the mom. And it's challenging for that mom in that situation. But then somebody, aside from the mom, somebody with impulse control challenges with her friends. Maybe she has friends she's reconnected with after she got out of the hospital, but she's a little more inappropriate. She's a little more, she's a little more gregarious and speaking more. And yeah, perhaps she's like, I've known cases where, someone like this might be flirting with her friends' spouses, and that's going to turn off her friends and she might not get as many invitations to hang out. And she doesn't understand why. And she might not even remember the incidents. So and that now she's feeling isolated and she can get depressed, right? So if we just give her an antidepressant, that's not really solving the problem. If she does therapy with somebody who doesn't understand the head injury, it may not really solve the problem. And it's not about solving the problem, but it is about understanding it and trying to live with it, creating the best quality of life as possible. Another example would be, like a 45-year-old father and husband with panic disorder. So panic attacks, extreme anxiety, heart racing and, sweating and feeling like he's going to die at times after having a moderate TBI. But this same guy has attention problems, executive functioning problems. And, he knows he makes a lot of mistakes. He's left the stove on because he doesn't pay attention. He's left the stove top running on multiple times and, things like that. And so he's away from his house for 5 minutes and he thinks, oh my God, did I leave the stove on? I'm gonna kill my kids. They're gonna die in a fire. Does my wife even know? And so it's not, it's not based on an irrational OCD like fear. It's based on some reality that he does make these mistakes more. Okay. I could go and I could elaborate on stories like this, but I'm really at risk of running out of time here. So, what might help mental health post TBI? Sleep is key. Sleep is not talked about enough. People, I think in America we're not good about, I could say, speak for myself, I can do better at making sure I sleep on a regular basis at the same times, get up at the same time, get my 7 to 9 hours. But after a head injury, this is even more important. Sleep is when the brain heals, and even if it's slow to heal, because people can heal for years to come, just day-to-day function can change quite a bit with sleep. One thing I think of with brain injury is we all have our good and bad days and how well we function, and that's true for somebody with brain injury. But their bad day is going to be dramatically worse than their good day, and sleep is key for that. Something I talk a lot about with patients is pacing their behavior and stimuli input. What I mean is like how much is somebody doing in one day or trying to get done in one day. That'll impact how much they can do the next day or even later that same day. And then stimuli, similarly, how loud or how bright or how much social stimuli is happening that will impact what they can do later. So, for example, somebody with a brain injury might decide, you know what, I really want to go to that football game, so I'm going to go, and I'm fully aware that I'm going to have to sleep like 12 hours after that, but it's worth it to me because I want to go to that football game. Or I'm going to go to that football game and I'm going to wear earplugs and sunglasses, and I'm going to every 20 minutes step away, go out in the parking lot, chill out for 10 minutes, and then come back and catch the game as much as I can and repeat that every 20, 30 minutes. And even though that's not the ideal way to watch a football game, they still get to participate and they're not totally burnt out at the end of the day the same way. So, it's really individual basis, but pacing oneself can be key. Finding ways to connect with others. This is really important for quality of life and mental and physical health for that matter. There's a big study that came out of, I think, Britain showing how much things like blood pressure, diabetes relate to, being isolated versus connected to others. So I could talk quite a bit about that. And I did mention some of the challenges for people with brain injury that can come with connecting with others. But then, I think the Brain Injury Alliance probably has like support groups and things like that. There might be different ways to connect with others that weren't happening before the brain injury. Accepting help and feedback from others, particularly for severe TBI. So I think it's great for people's mental health after they've had a severe TBI to be more open to help from in a way that they might not have been before. And it's frustrating because, like I said, a lot of people with severe TBI a year, 2, 3 later, they think they're doing great or not, but they might think they're doing wonderfully, and they find it challenging to have a family member constantly getting on their case about something. So reframing that as this person's here to help me, it's my choice to accept that help. And this is oversimplifying things, but for the sake of time, I think it's just something to raise one's awareness. If somebody sees their general health, their mental health as a team effort, then accepting the help and feedback of others, because somebody with TBI may not be aware fully of what's going on with themselves. I mean, this is probably true for all of us, whether they have a brain injury or not. I think we're not all aware of how we're functioning, and sometimes others can see how we're doing in a way that we're not seeing. Strategies for cognitive challenges. This is something where, there's a lot to say here, but this is where cognitive rehabilitation can be quite helpful. Working with a skilled speech therapist or occupational therapist who knows cognitive rehab can teach somebody, how do I compensate for my memory problem, or how do I maybe improve my attention somewhat and then compensate for the rest of the challenge, so that it doesn't impact my mental health so much. Obviously, drugs and alcohol aren't particularly good for any of us after brain injury. It can have a particularly big impact. And then managing stress, which is a huge category and probably worth its own webinar, but finding ways to manage stress, because stress impacts how well we function cognitively, emotionally, behaviorally, and how we connect with others. So finding ways to manage that is key. And then exercise, and of course you want to check in with your doctor, but to make sure it's safe. But it could be just light exercise, walking, gardening, something but it's done frequently. And this is good for the brain, good for mental health. Okay. Other things to consider. So I think, I mean, obviously I'm a psychologist, but I think psychotherapy, including family therapy in particular for people with brain injury, more so than, thinking of adults, for example. Most adults, when they go to therapy, they don't go to family therapy. But when I see an adult who's had a brain injury, I almost always will ask if we can include whoever is closest to them in several sessions, because it helps raise one's awareness of what's going on with them, all the reasons I was saying earlier. And it's often a family issue. And it can be helped by the family understanding things even more and coming up with new ways to do things. Neuropsychological evaluations are good for raising one's awareness of where the challenges are. They can also, a neuropsychological evaluation, which is a comprehensive evaluation of cognitive and emotional functioning, and it can help guide treatment with things like cognitive rehabilitation, but also sometimes can guide other forms of treatment, psychotherapy, even some medication choices. But for the individual living with it, and the family who lives with the person who has the brain injury, helps raise awareness of where is this person's challenges. And then I've mentioned these sort of therapies before are also good. Support groups, organizations like the BIANJ, and then other professionals out there to help with mental health, as long as they have experience working with brain injury. So I think just really quickly, I'll pick a couple here, but you can see these are some examples of strategies. We talk about compensatory strategies. So things like shared calendars with a family member, using alarms and timers, prospective memories, like remembering what I need to do in the future. While none of us should probably be relying on our brain for that, but certainly after brain injury, we need most things external to our head. As in, can I write it down somewhere? Can I use an alarm or a calendar to remind me? And then sometimes things like journaling what I did for the day, so I can go back and look at it later or next week. Trying to make sure to single task versus multitasking. All these things are to help cognitive function, but again, helping cognitive function can't help mental health as well, emotional functioning. And then this last one is saying, like I was saying earlier, relying on your team, your family, more to support you um, if you have a brain injury is important. All right, and we now have just a few minutes for questions. So I thank you all for having me, and I will leave it at that. I'm gonna, I guess, stop sharing my screen.
All right. Thank you so much, Dr. Cohen. And for anybody who needs to hop off, we did put in the chat the link to the survey. So feel free to complete that, get your certificate. But if you would like to stick around, we'll take a couple of questions that we have here in the Q&A. So Dr. Cohen, we have a couple of questions around any suggestions for dealing with insomnia.
Oh, wow. Yeah, that is a tough one. I would say, and it's gonna, whoever's asking the question may have looked into this or heard this before, but some of the key things are keeping sleep times regular, especially the wake up time is the key. So waking up at the same time every day so that your body's used to waking up then and getting tired at the same time. And then I would suggest a person read up on sleep hygiene practices. That's really what I'm about to launch into, and I could talk for an hour about that. But reading up on sleep hygiene, what activities to do before bed, what not to do, what to do if you wake up in the middle of the night, what not to do, and you can work with a skilled mental health professional on that, or a skilled doctor for that matter. But somebody who knows sleep well. There are people that can guide you. There's a form of therapy called, for example, called cognitive CBTI, cognitive behavioral therapy for insomnia, and there are people certified in that. You can seek them out, and they can guide you very specifically. But there are ways to help it. It helps if the person also understands brain injury and how that plays a role. Yeah.
Great, thank you, Dr. Cohen. Another question about what you had mentioned in the beginning, the brain injury resources that's coming to Rutgers. They were wondering if it was limited to students. It sounds like
No,
maybe
it will not be.
All
It
right.
will not be limited to students. I don't know when it's going to happen. I almost hesitated to say that out loud, but it will. I do plan for it to happen. I just it might be a few months. But in the meantime, I think finding other brain injury specialists would be key. Neuropsychologists, physiatrists, uh, rehab centers.
Great. It's actually a good segue into the next question. This person was wondering if after sustaining a TBI, is it necessary or recommended to find specialized providers like versus a regular psychiatrist? Should you find a neuropsychiatrist or versus a regular psychologist, a rehab psychologist?
Yeah, it's a great question. And I wish I could say there's just not a lot of neuropsychiatrists. And it's a mix on which of those really are actual neuropsychologists who are good at, so neuropsychiatrists rather. I would say if the person needs medication for mental health purposes, a case by case. So if somebody didn't have much mental health challenges before the brain injury and now they have the mental health challenges a lot afterwards, I would go towards a provider who is a brain injury specialist, and it doesn't have to be a psychiatrist. Obviously, a psychiatrist who knows brain injury would be excellent, but you could go to a physiatrist or a neurologist who knows brain injury and also is used to treating, let's say, anxiety or depression after brain injury. So some physiatrists, which are rehab doctors, are excellent with antidepressants, for example, or mood stabilizers, and so I know like at JFK Medical Center or down south, I'll blank on the name, Johnson Rehab Institute, and then Kessler, their physiatrists have done a lot of treating psychiatric, uh, challenges. So I would do that. If the person already had a psychiatrist before the brain injury, I would stick with that person and ask them, do you think I should see somebody who's a brain injury specialist?
Okay, great. Do you have a couple more minutes for a few more questions? Or
Sure.
okay.
Sure.
We have a question here saying that they struggle to get their friends and their family members to understand what they're going through. What do you recommend of how to communicate with them and help them understand?
This is a huge challenge. I sympathize with this person. Um, you know, it'd be great for them to, come to webinars like this. If you could bring a family member that you really want to understand, bring them, to places that are not just you trying to explain it. So like, I think it's powerful for a family member to hear, so what's very common, somebody has what's considered a mild brain injury, a concussion, and they have massive changes to their functioning in their life, and the family or friends around them don't understand. So if, however, that person can help their family get education, and if it's from somebody like me or somebody else, where they can go to somewhere and hear about it or read about it, they can see, oh, wow, this person I love who had a brain injury is experiencing a lot. A lot of people experience the exact same thing, and it starts to help people understand like that's not, something particularly, especially wrong with my family member here. This is what happens to people with brain injury. So I know it's probably not the most satisfying answer, but it's trying to find other sources of education. And part of it is getting, if people aren't willing, I mean, if you could bring them to a therapist who specializes in brain injury, that'd be great. I want to just say, if you can't find a therapist who specializes in brain injury, the next best thing, and it's still worthwhile, is a therapist who's willing to work with you and also educate themselves a little bit about brain injury. I think therapy can be helpful still, and as long as, if you get the sense they're not really willing to consider the brain injury as part of it, then I wouldn't stick with that person. But
Great, thank you. And we have someone here expressing that their family's not very involved and they have to handle this a lot by themselves, and so they do go to support group, but it only happens a couple of times a month. So what would you recommend? What are other ways that they can find support and strategies for themselves throughout the rest of the week that they're not involved in these support groups?
yeah, well, if the person hasn't already gone to well, even if they have gone to like a comprehensive rehabilitation program, you know, um, where there's, like I said, speech therapy, occupational therapy, that do cognitive rehab. I think those are good places to learn new strategies or refine old strategies. So I've known people that will go to cognitive rehab. So a place like I said, Kessler Rehab Institute, JFK. Um, there's a handful of others, and then even some private practices are very good with cognitive rehab. And um, you can go more than once. So a person could go and then 8 months later say, I'm really struggling again, go back to that rehab team and refine some of the things they were doing. Say, oh, this isn't working for me anymore, or I can't figure out how to do this, get through this kind of challenge. And somebody can sit with you. And that, again, that could be a speech therapist, could be an occupational therapist, as long as the person's trained in how to do it.
Great. Okay, just a couple more, maybe one or two, so we can end here. One person is asking if you have any strategies for impulse control.
That is incredibly hard. I think it's a hard one. I would say, working with a skilled therapist, there are some medications that can help with that. Uh, you know, the, you know, so for example, some of the medications for ADHD can also help impulse control for people with brain injury. It's considered off-label use. But if you're looking long term, um, like I said, a skilled therapist that helps. Maybe they're not even a brain injury specialist. They could be a specialist in ADHD. It's not ideal, but it could still work if they know how to help somebody who has impulse control issues. And because ADHD is so common, there are a lot of therapists that specialize in that. So you might say, hey, listen, I don't have ADHD, but I have a brain injury. I have impulse control challenges. Could we meet and you can help me develop some strategies? I realize that it's hard for me to answer that question because like directly to this person because everybody's a little different. That's why going to a skilled therapist would be helpful. And then on top of that, things like learning mindfulness-based meditation or mindfulness practices, because part of the challenge is raising awareness of when the impulse is going to happen. And so a lot of therapies will include mindfulness. And as I say that word, I'm realizing a lot of people don't know what that means, but it's being aware of the present moment as it's happening, including body sensations, cognitive and emotional impulses, and learning how to be aware of them so that we don't react to them immediately. And that takes a lot of practice and usually some coaching on how to do that. So uh, between therapy, mindfulness exercises, and then maybe medication, there is certainly ways to improve there.
Great. Just for the sake of time, I'm going to end with one last question. And if anybody has any others, you can feel free to reach out to us and I'll be happy to, move your question on toward Dr. Cohen. The last question here is, how can you fall into the category of mild, with respect to consciousness, but have all the moderate and severe symptoms? Is that some type of misdiagnosis? How does that work?
No, yeah. So that's a good question. And what I'm saying is, so the symptoms can be severe. The categories have nothing to do with how well the person's functioning, if that makes sense. So I say that because it feels invalidating. Like people feel like you're minimizing my problem when you say I have a mild brain injury because the symptoms are severe, but the category is based on how long did their memory problem last. They're right after the injury where they had severe post-traumatic amnesia, where they like don't remember anything, they can't form new memories, or how long was the loss of consciousness. So if those are the way their brain injury has been categorized in their medical record, that doesn't say anything about how much it's changed their life afterwards. So it could be a severe consequence to their life, even though it's called a mild brain injury, because the category is not about the symptoms and the functioning. It's about whether it's level of consciousness, post-traumatic amnesia, something else.
Yes, great. All right, well, for the sake of time, we're going to cut it off there, but I thank you so much, Dr. Cohen, for joining us and sharing this presentation and taking all these questions, staying off there a little bit. So thanks again for everyone joining. And if you haven't already, please fill out that survey link in the chat and you'll receive your certificate if you need one. So thanks for joining and we hope to see you at the next webinar. And this concludes today's webinar.